Hello, I'm Dr. Deepak Bhatt from Brigham and Women's Hospital and Harvard Medical School, and it's a pleasure to provide a recap of the latest findings from the Symplicity Hypertension 3 trial. Symplicity Hypertension 3 was a randomized sham-controlled trial of renal denervation, and renal denervation refers to a catheter-based approach of ablating sympathetic nerves around the renal arteries to reduce blood pressure. So we wanted to test in what at the time was the most rigorous design, a sham control design, to see if the initially very promising reports of renal denervation in uncontrolled studies could be replicated. And in this population of patients with resistant or poorly controlled blood pressure, at the 6-month primary endpoint, we did demonstrate safety, so the safety endpoint was met. However, the efficacy endpoint was not met. The primary efficacy endpoint at 6 months was office systolic blood pressure, and indeed, there was a significant difference in the renal denervation arm from baseline to 6 months. However, there was also a significant reduction in the sham control arm, such that the difference between those two differences was not significant. So the primary efficacy endpoint wasn't met. However, as published in New England Journal of Medicine in the subgroups, we did find some evidence of efficacy. And likewise, in subsequent publications, we did find some secondary endpoints that were significantly affected at that 6-month time point. However, one needs to be cautious about such subgroup data and such secondary endpoints. But now we've had the opportunity to analyze the entire data set to the full extent of follow-up in some patients going to 4.5 years. And I think we find much more information than was initially available. So what we did for this part of the analysis, the most recent update to Symplicity Hypertension 3, is examine the maximum follow-up. And with 4.5 years of follow-up in some of these patients, it's really the largest experience we have with renal denervation in a sham-controlled trial. Now, the way the trial worked is patients were initially randomized to renal denervation or to sham control, and then at 6 months, unblinding occurred. So patients were no longer blinded after that time point, nor were the people assessing the blood pressure. And we followed the patients in the renal denervation arm, those initially randomized to renal denervation, for the full extent of the follow-up period I mentioned. Those who were initially randomized to sham control, well, then they consisted of two subsequent groups of patients that we treated as control patients. But there could be those patients who at 6 months continued to have out of control blood pressure. So patients that were really difficult to treat, where even after that 6-month period, the blood pressure is totally out of control. Those patients per protocol crossed over to renal artery denervation. Whereas the patients that didn't cross over, that meant between 0 and 6 months, for whatever reason, their blood pressure was no longer out of control. And that's probably because in that sham control arm, those patients actually really started taking their medicines, whereas before they entered into the trial, well, they were saying they were taking their medicines, but perhaps they really weren't, or they weren't fully taking all their doses of medicines, probably a so-called placebo or Hawthorne effect that is actually observing something changes the experiment. So probably just having those patients in a situation where there's a research nurse asking, hey, did you take your blood pressure medicines today? If you didn't, you could have a stroke. Probably in that milieu, patients who maybe normally weren't so adherent became more adherent. So at any rate, we followed all these patients, and the patients who were randomized to the sham control, but who crossed over per protocol to renal denervation, we used their blood pressure before the renal denervation procedure and imputed that using a last observation going forward. So at any rate, some complex, sophisticated statistical methodology. But the bottom line is, with this longer term analysis, we did indeed see safety that was confirmed out to long-term follow-up with no late emerging complications. But I think more interesting, we did actually find efficacy. That is, at the 12, 24, and 36-month points, we did see significant changes in office systolic blood pressure in favor of renal denervation versus our control group. And out to 4.5 years, there weren't really that many control patients, so we couldn't analyze those. But in the patients who underwent renal denervation initially, we see, if anything, no attenuation of the blood pressure reduction from renal denervation, and in fact, a suggestion that was statistically significant that there is even greater reduction evident in the renal denervation patients with longer term follow-up. And might that reflect some underlying change in the biology with the ablation of the sympathetic nerves? Possibly. It could also just represent that in the control arm, whatever placebo or Hawthorne effects we saw during the blinded masked phase of therapy dissipated. That is, if there are placebo or Hawthorne effects, you wouldn't really expect them to last, for a couple of years or 3 years. So probably this allowed us to see the quote unquote real effect of renal denervation emerge. And in the control arm, we saw what happens in real life when patients aren't in the artificial constraints of a clinical trial. So significant changes in office systolic blood pressure, also significant changes in office diastolic blood pressure, in ambulatory systolic and diastolic blood pressure, as well as the time and therapeutic range, which was significantly improved with renal denervation versus control. And by that, I mean the 24-hour systolic blood pressure, whether one looked at nighttime, morning, daytime blood pressure, significant reductions in the renal denervation patients at 36 months versus baseline, not seen in the control patients. So overall, a message of consistency within this data set that with longer term follow-up, there did indeed appear to be a significant reduction in blood pressure. It's important to view these results, the final follow-up results from Symplicity Hypertension 3, in the context of what's going on with renal denervation overall. And these data that I just mentioned were published in The Lancet for anyone that wants greater details. We do lots of different imputation analyses, sensitivity analyses in the paper and the supplement, and everything's pretty consistent. And I think viewed with all the evidence out there, provides further consistency that renal denervation does lower blood pressure. There have been now a number of sham-controlled trials that followed after the design of Symplicity Hypertension 3, improved upon the design of Symplicity Hypertension 3 with measurements of blood and urine metabolites to see if patients really were taking their blood pressure medicines or not. And with these subsequent trials, the majority of them have shown a statistically significant reduction in blood pressure. So I think, again, viewing the totality of evidence out there, it's pretty clear renal denervation works. We used a radiofrequency catheter. There's a second generation catheter now that provides even greater blood pressure reductions. There's an ultrasound catheter. There's some other experimental systems that are being tested. But it does seem to be a pretty consistent message that ablation of sympathetic nerves in the renal arteries done percutaneously really does lower blood pressure. So I think the total landscape now of renal denervation is more or less consistent in providing, I think, pretty strong evidence that renal denervation does lower blood pressure. So renal denervation in the United States, for example, is not FDA approved, but in other regions of the world, regulatory agencies have already approved it. I think that patients in regions where the therapy is approved might benefit from this therapy if they've basically exhausted all other means. So patients that are completely maxed out on lifestyle modification, on use of multiple medicines, typically these are generic medicines, multiple medicines, and their blood pressure is still out of control, well, those patients are at high risk for stroke and heart failure and cardiovascular death and so forth. So there, I think the reality is we need to do something for those patients. Right now, we don't have anything more to offer them because they're already doing as much as they and their doctor and their healthcare system can possibly do to get their blood pressure under control. In that circumstance, I think if available in experienced hands, renal denervation could be a very valuable option. So I see this in the future being part of the armamentarium of the management of complex, resistant, poorly controlled, uncontrolled hypertension. There are a few different terms that are somewhat overlapping, but basically that patient where, as a doctor, you've done everything you can and their blood pressure is still out of control. I think in that sort of patient, it makes sense to consider renal artery denervation, again, assuming it's a region where the therapy is approved. There's certainly more we need to learn. It would be terrific if we knew exactly which patients might benefit from renal artery denervation a priori. Within the patients that have undergone renal artery denervation, there's some that seem to have very large responses and others that don't. And yes, it's possible that's technique dependent, but I think there's something more fundamental. So I think there are likely patients that are having the right phenotype to benefit from this among the many patients with uncontrolled hypertension. But right now, we don't know how to identify it. So right now, other than the ways I mentioned, that is somebody that has out of control blood pressure despite being maxed out on lifestyle modification and medications, we don't really know who to identify, how to identify patients that might be the ones most likely to derive a large benefit in terms of blood pressure reduction. So if we could figure that out, that'd be good. The second point I would raise is that it'd be nice to know at the time of the procedure, did it actually work? If the operator could get some feedback, was this a successful renal artery procedure? And right now, there's no way of knowing that. So it's a little bit of just hoping that the technology, when applied the way it's supposed to be applied, does what it's supposed to do. It's very different in the cath lab than, say, putting in a stent, where if there's a 99% proximal AD lesion, you put a stent in, there's TIMI3 flow, you know that it was a successful procedure. With renal artery denervation, you don't really know at the end of the procedure whether you accomplished everything you wanted or not. And the final point I'll make is that, of course, it'd be nice to have a large cardiovascular outcome trial. That is a trial not just demonstrating blood pressure reduction, but reduction in things like stroke and myocardial infarction, heart failure, kidney failure, et cetera. That, however, would be a large, expensive, logistically tricky trial to conduct. So I'm not sure that that's actually going to happen anytime soon. But ideally, that would be the way to link the reductions in blood pressure that we're seeing with renal denervation to what we assume, I think logically so, should be reductions in cardiovascular events. Still, it'd be nice to prove it. I mean, that would really be the bookend on the renal denervation story to say, yeah, this absolutely should be standard of care. And it would also, I think, help it expand potentially out of the narrow sort of patient population that I defined who might benefit, such that it might be applied even to people with more moderate degrees of hypertension or early on. But before I would recommend or endorse any of that, I think there would need to be such a cardiovascular outcome trial. But for the time being, again, we're approved, I think, for patients that have totally out of control blood pressure. They're coming in the emergency room, 200 over 120, despite seemingly doing everything possible to have their blood pressure controlled. And that sort of patient, I think it makes sense to offer renal denervation as opposed to just, letting nature take its course, which might mean a stroke.